So we just have one lecture on the endocrine system, hormones. It's a big topic. There are a lot of people that have endocrine problems. There are a limited number of different conditions that you need to know, so it only comes in one lecture. So remember, after this single lecture, you're going to have your quiz on this topic. Covered in A&P 2. I assume most of you have had A&P 2 by now, but I'm going to go over a couple of things in basics of endocrine function because they relate so closely to what your signs and symptoms are when you actually have an endocrine problem. So the endocrine system produces hormones. There are paracrine substances produced too that just move through the interstitial fluid from one cell to the other. That's separate from this, though. We're mainly talking about the true endocrine hormone production, which is signaling molecules produced by cuboidal secretory cells that are in clumps that are glands, like the thyroid gland, the pituitary gland. They're released into the bloodstream. They go to a target cell, they bind to a surface receptor and cause that cell to do something, whatever that cell is designed to do. We have two basic kinds of hormones. We have water-based hormones that are mostly peptides, and they travel quickly through the bloodstream. They're easy to dissolve. They generally act on surface receptors on cells. Because they're water-based, they can't cross the membranes. And we have lipid hormones, which are your steroids and your thyroid hormone. Those are lipid-based. They have to be bound to a transporter so they can be carried in the blood. But once they reach the cell, they can go right through the membrane because they're lipid-based. They tend to act on the nucleus and cause protein synthesis and cell changes that way. Regulation is negative feedback. Whatever the outcome of that is, that outcome will shut the system down. So you don't run away with any of the hormone production. When you're, if you make thyroid hormone, you produce your thyroid releasing hormone from the hypothalamus, causes the pituitary to release thyroid stimulating hormone. It stimulates the thyroid, which makes your thyroid hormones, thyroxine mostly. Thyroxine then it inhibits both the hypothalamus and pituitary from releasing their stimulating hormones. And so that's the negative feedback system that is supposed to exist. Hypothalamus is the main control center. It will receive information from all parts of the body about your temperature, about your blood pressure, your blood osmolarity, all manner of things. It will release hormones called releasing hormones down into the pituitary stalk that will cause the anterior pituitary cells to release hormones out into the bloodstream. So the hypothalamus stimulates the pituitary. The pituitary is the distribution center. It sends out the hormones that will actually turn on the glands that will do the final job. So those target glands, the thyroid gland, the adrenal cortex, and so forth, will then release their hormones, thyroid hormone, cortisol, and so forth, which will then stimulate your body's cells. Many of the surface receptors, most of your hormones are water-based. Most of those surface receptors are G proteins. Remember, G proteins, they bind to the surface, activates a membrane-bound G protein on the inside of the membrane, turns on an enzyme, makes stuff. You make cyclic AMP, trying to say that, cyclic AMP. It makes phospholipase C, which causes you to release calcium from your endoplasmic reticulum. And these are some of the main ways that your hormonal system, just like your autonomic nervous system, can stimulate cells to either increase or decrease their activity. The GS proteins make cyclic AMP. GQ proteins release calcium inside the cell. A good, very basic way to remember what their main activity is. And some, your growth hormones and insulin, use a catalytic receptor which has its own catalyst on it, its own enzyme that is going to cause cell changes. Okay. So here we go. Here's the hypothalamus. We have growth hormone releasing hormone, corticotropin releasing hormone, thyrotropin releasing hormone, gonadotropin releasing hormone, prolactin releasing hormone, and those will go down into the anterior pituitary and cause you to release growth hormone, adrenal cortex stimulating hormone called adrenocorticotropin hormone, thyroid stimulating hormone to stimulate the thyroid gland, your gonadotropins, follicle stimulating hormone, and luteinizing hormone stimulate ovaries and testes to do their thing, and prolactin, which stimulates the breast to make milk. Posterior pituitary gets hormones directly from the hypothalamus. Oxytocin is a muscle contractor that causes milk to be released for the baby when it's suckling and causes uterine contractions for childbirth. An antidiuretic hormone which causes you to retain water. The more of this, the more water you retain. Antidiuresis. So that's kind of a quick review. Here's a slide I use in AMP2 that I like a lot. It looks complicated, but here we have thyrotropin releasing hormone in the hypothalamus, causes you to release thyroid stimulating hormone in the pituitary, causes the thyroid gland to release thyroid glands, which then go to tissues and do their thing. And so each one of these hormones, if you haven't seen this in a while, you may want to look at this and follow this pathway, because if you have a problem here, it causes certain things. If you have a problem only here, it causes other difficulties. And here I've put a cheat slide for you just to give you the basics of what your main hormones do. Thyroid hormone increases metabolism. Cortisol, the stress hormone, causes energy distribution and fat deposition, and it also suppresses the immune system. Like hydrocortisone cream is cortisol. Growth hormone makes you grow. Testosterone and dihydrotestosterone make your muscles grow and maturation of body parts. Parathyroid hormone increases calcium in your plasma by making you absorb more and also taking it out of your bones. Calcitonin is the reverse. It puts calcium in the bones. Insulin lowers your plasma glucose by causing you to take it into your skeletal muscle cells. Glucagon raises your blood sugar by causing your liver to release some glucose. Aldosterone causes the kidney to retain sodium and, as a result, retain water. Antidiuretic hormone causes your kidney to retain pure water. Has a slightly different effect than aldosterone. Oxytocin, muscle contraction and milk let down, and prolactin causes breast tissue to grow and start making milk. So those are your main hormones right here, and the main one thing that they do, that if you notice this was too much or too little, you would know it was caused by that hormone. They have some other smaller effects too, that if you, once you get really into medicine, you'll want to know a bit more than that, but this is a good start. So what can cause hormones to go haywire? Well, the negative feedback mechanisms. For instance, if you are overstimulating the hypothalamus or the pituitary, you're going to cause too much stimulating of your glands. If something causes them to negatively feedback too much, it'll shut them off. If you don't have enough iodine, you can't make enough thyroid hormone. Not enough thyroid hormone, you don't negatively feedback your hypothalamus and pituitary. You stimulate the thyroid so much it grows the size of a volleyball. It's called a goiter. So negative feedback mess-ups. Dysfunction of the gland itself. It can have been damaged by disease, by infection, by an infarct that blocks blood flow to it. It can have an overgrowth, a tumor, an adenoma, means a gland tumor. And so it has too many cells making too much stuff. The secretory cells may not be able to produce or obtain the precursors for that hormone. Thyroid hormone is made out of, it needs iodine, tyrosine and iodine. If you don't have enough tyrosine, you don't have enough iodine, or you can't take it in, maybe you just can't make the hormone that way. Maybe too much, a tumor, an adenoma. Is that the hormone may be attacked or broken down in some way before it gets to where it can do its job. You can have another tissue releasing some excess hormone that is either the same or mimics one of your hormones. The target cell can have a problem with the surface receptors, too many of them, too few. Insensitivity, like insulin receptors become insensitive with type 2 diabetes. You can have antibodies that fight your own receptors and damage them, or antibodies that act like the hormone that's supposed to turn on the receptor and overstimulates those receptors. So now let's start looking at a few of the different problems that these things can cause. Let's look first at the posterior pituitary. This is brief. Oxytocin comes out of there and causes uterine contraction and milk letdown for suckling. But there are few problems with excess or insufficient oxytocin. But antidiuretic hormone, the other one that comes out of there, causes you to antidiuresis. In other words, you don't pee as much, you retain water. So if you don't have enough blood pressure, or if your blood has become too thick because you've sweated too much water out, you'll produce more ADH and you'll retain more water to raise your blood volume back up and thin it out some. So that's good. However, if you make too much or too little ADH, it's going to cause the very problems that you're trying to prevent. The first of these is too much ADH. And they incredibly decided to call it syndrome of inappropriate antidiuretic hormone, SIADH. Why didn't they just call it ADH toxicity? Toxicity means too much. Or anti-ADH. Syndrome of inappropriate antidiuretic hormone sounds like it could be either too high or too low. But in fact, this means too much ADH. So try to remember that one. So if you're making too much ADH, you're retaining too much water. Pure water. Does two things. Makes your blood volume go up and your blood pressure go up. The other problem is it thins out your blood too much. You're just pumping pure water into your blood, and so you become hyposodium, hyponatremia, hypocalcium, hypopotassium, hyperosmolarity. Not enough ADH is called diabetes insipidus. The term diabetes means too much water. You pee too much. Diabetes mellitus is caused by having too much glucose in your blood. When it goes to the kidneys, you can't reabsorb it all, so it goes out in your pee, and the osmotic forces pull more water in, and you pee too much. Diabetes insipidus, you don't make enough ADH. If you don't make any ADH, you just pee all the time, and you're so dehydrated you can barely survive. So polyuria, too much pee. Polydipsia, you're thirsty all the time. I think of dipping water out of a bucket. Polydipsia. Can't concentrate the urine because you're supposed to retain most of your water, not pee it out. You can have a problem with the hypothalamus, which actually sends ADH through a couple of nerves down into your posterior pituitary. You can have problems at the kidney where you can't respond to the ADH. But here, you become dehydrated and your blood is too thick because you're not peeing out solute, you're peeing out water. Hyperosmolarity Hypernatremia, too much sodium in your concentration in your blood. Not more sodium, just too much sodium compared to the amount of water that's there. Anterior pituitary has all the other hormones. It's got growth hormone, and it's got, thyroid stimulating hormone and ACTH. So what if we have a problem with the anterior pituitary? Well, let's start off with not enough. You can have a damage, shock, disease, or something that might damage that little P-shaped thing so that it can't make enough. Tumors. And hypopituitarism can cause a decrease in whatever that hormone is designed to do. It can be a single hormone or it can be all of them. If it's all of them, it's called pan-hypopituitarism. Pan is like pandemic. It means everything, widespread. So pan-hypopituitarism, you couldn't make enough adrenal corticotropin hormone. In other words, you can't stimulate the adrenal cortex to make cortisol. You don't make enough thyroid stimulating hormones, so you have hypothyroidism. Insufficient gonadotropin, so the gonads don't develop properly and don't function properly. Growth hormone deficiency, dwarfism. Lack of growth hormone will cause this 17-year-old boy who's barely over a meter tall. Hyperpituitarism would cause all these to be excessive. Hyperthyroid, we'll talk about that separately a little bit. Hypergrowth hormone, grow too much. Hyper-ACTH, you might make too much cortisol. Overgrowing, it can be a particular hormone if you have just those cells are growing a tumor that's making too much of that hormone. Or it can be a pan-hyperpituitarism as well. Look at some of the various hormones that would be affected. The opposite of dwarfism is gigantism. It looks like giantism, but it's actually pronounced gigantism. Here's Henry Wadlow. He was 8'11". If you have too much growth hormone from the time you're a baby, before your growth plates seal, you grow tall, tall, tall. If you develop a tumor later in life, after your growth plates have already sealed, you don't grow taller as much as you grow thicker. The bones get thick, the jaw gets thick, the fingers get really wide, and that's called acromegaly. Acromegaly, too much growth hormone later in life. Gigantism, giantism, grow especially long because you had it early in life. Gigantism. Another big guy. It's really hard on you. Henry Wadlow died at something like age 22. If you make too much prolactin, prolactin is the hormone that causes breast development and milk production. Well, it also causes some various other hormonal changes because too much prolactin, prolactinomas, these are tumors within the breast that are making too much prolactin. They are the secretory cells in there that have gone out of control a bit. It's not breast cancer. You're making too much prolactin. Amenorrhea, if you're producing milk, you're less likely to menstruate. Galactorrhea means a flow of milk out of your breasts. Hirsutism, the woman grows excess hair on her face and other body parts. And osteopenia, because of the amenorrhea, the subjugating of the hormonal changes that go along with the menstrual cycle, it causes osteoporosis or osteopenia. With males, it suppresses the male hormones, hypogonadism, small testes, erectile dysfunction, oligospermia, they don't make as many sperm. Thyroid malfunction is actually relatively common for a couple of reasons. Your thyroid hormones, thyroxine is T4, you also make T3, and they both have thyroid type effects on most of the cells in your body. They increase metabolism. They make your heart beat faster, they make you sweat more, they make you hot, they make you breathe faster, they make you burn up your calories faster, so people that are hyperthyroid tend to be skinny. Thyrotoxicosis means too much thyroid. Toxic levels or of anything are too much. So thyrotoxicosis can come in from a couple of different reasons. Graves' disease is an immune disorder, autoimmune disorder, where those antibodies actually attack the thyroid receptors on the thyroid gland and cause you to make too much thyroid hormone. They overstimulate it. So your own body is causing you to make too much thyroid hormone. Graves' disease. Myxedema, it causes accumulation of different kinds of carbohydrates in your cells and causes the cells to swell up and causes a non-pitting edema where the cells are swollen up. You can also have a hyperthyroidism because you actually have growths on the thyroid that are growths of extra thyroid cells that produce too much thyroid hormone. So that's kind of a different kind of thing. You get a goiter in this case. A goiter just means a swollen thyroid. If you're having a growth of nodules on the thyroid, it gets a little bit big, and you might be able to detect it, palpate it. Rapid heart rate and breathing, excessive use of nutrients makes you skinny, overstimulation of muscles gives you a muscle tremor, you're overheated. So hyperthyroidism, the thyroid gland is putting too much thyroid hormone, so it suppresses your production of TSH, of thyroid stimulating hormone. So TSH tests are often used for thyroid function. If TSH is low, you assume thyroid is too high because it's suppressing the production of TSH. If TSH is really high, you suspect thyroid function is too low because now there's no negative feedback happening. Radioactive iodine uptake and scan allows you to assess. Your thyroid gland takes up the iodine really well to make thyroid hormones. So you put a little bit of radioactive iodide in your blood and it'll suck it in and you can see where it's going. Thyrotoxicosis. Another thing that happens is you develop this exophthalmos, which means bulging eyes. And what it really does is it causes your eyelids to retract so that your eyes stick out. It doesn't make your eyes big, your eyeball bigger. It pulls the eyelid back. Marty Feldman made a movie career out of being a weird character because of his Graves' disease. Young Frankenstein. Hypothyroidism is exactly the opposite. You can have a couple of different problems. You have an autoimmune problem. Hashimoto's disease is where the autoimmune system kills the thyroid instead of overstimulating it. So you can have an autoimmune that gives you hyper and a different one that gives you hypothyroidism. Postpartum thyroiditis. During pregnancy, women have elevated metabolism to provide extra blood flow and oxygen and everything to the growing fetus. This stimulation of the thyroid gland that comes with those hormonal changes causes a hyperthyroidism during pregnancy that is desirable, but it often damages or sometimes damages the thyroid gland. So when you're done, postpartum means after birth, you have a thyroid gland that doesn't work as well. And some women are left with lifelong hypothyroidism after childbirth. Sometimes it recovers, sometimes it doesn't. Endemic goiter is endemic means that it's localized to a location. West Nile virus is endemic to the Caribbean. Endemic goiter means that you don't have enough iodine in your diet in a town in Central Africa or someplace that's far away from the ocean and never had enough iodine deposited in the soils or whatever. And as a result, you can't make enough thyroid hormone because it requires iodine. So low thyroid doesn't negatively feedback the thyroid stimulating hormone. It stimulates so much you grow a big giant thyroid gland. And so endemic goiters are iodine deficiencies. Idiopathic goiters, it just doesn't work for some reason that's not obvious. And you can have thyroid cancer that may destroy the thyroid, and anyway, you have to take it out, and then you really are hypothyroid, and you have to take thyroid supplements the rest of your life. Here's a girl with a goiter from a town that had no iodine in their diet. That's the thyroid gland under there. This guy, too, had a goiter, but after he was treated, the goiter went away. Here we have too much thyroid, too little thyroid. Too much metabolism, skinny. Too little metabolism, you tend to get fatter. You have swelling from that myxedema and stuff, and you have a hard time staying awake because your metabolism is so slow. The parathyroid glands sit on top of the thyroid glands and make parathyroid hormone. Parathyroid hormone does everything you need to increase blood calcium. You absorb more at the gut, you retain more at the kidneys, and you leach it out of the bones if necessary to keep your calcium levels up. Parathyroid hormone keeps calcium levels up. So what would happen if you had too much of it? You'd have too much calcium. Okay? Hypercalcemia. It could cause kidney stones. It could cause soft bones because you're constantly leaching calcium out of the bones. It can cause hyporeflexia because too much calcium causes muscles not to stimulate properly. Too little causes muscle cramping. Too much causes flaccid muscles, hyporeflexia. Not enough parathyroid hormone, calcium is low. I mean, it keeps your calcium up, so too much, too high, too little, too low. And remember, hypocalcemia causes muscle cramping because the calcium is not there to control muscle stimulation. Diabetes mellitus, some people will say, mellitus. You have type 1 and type 2. Type 1 can be caused by a couple of things. It's autoimmune or not. Type 1, it could be that you have your beta cells that make insulin are not functioning. If it's autoimmune, your immune system is attacking the cells so they can't function. You don't make enough beta cells, and you don't then make enough insulin, and therefore your blood sugar stays in your blood instead of going into the muscles where it's supposed to go. Primarily, you can't make enough insulin. You're born with it. It's a genetic problem. You can't make enough insulin, and you tend to be skinny, you tend to be weak, you have a lot of vascular problems, but you control it with insulin injections. Type 1, hyperglycemia, too much sugar in the blood. Polydipsia, you're thirsty all the time. Polyuria, you're peeing all the time. Remember, the way that diabetes mellitus works is that you have so much sugar in your blood that when your kidneys filter the blood to clean it, you can't reabsorb all that sugar. A decent amount of it stays in the urine. It comes out in the urine. So you have glycosuria. You measure it. Oh, there's glucose in here, which means that you have extra solute. It pulls water along with it by osmosis, and you pee too much. So you pee too much, you're dehydrated all the time, you're thirsty all the time, you're hungry all the time because your cells aren't getting the glucose that they need. And so you're constantly sending out signals saying you need more nutrients. Polyphagia, hungry all the time. Weight loss, you can't get enough nutrients into the tissues. Type 2 diabetes mellitus is a whole different thing. It manifests the same in some ways, but it's usually caused by obesity and inactivity, but obesity, which causes you to change your hormonal ability to deal with glucose. It changes your some of the structure of your blood vessel walls. It changes your it depresses your ability to respond to insulin. So the walls of your tissues, have insulin receptors on them. With type 2 diabetes, you're making insulin, but the receptors won't respond. so the blood sugar still stays in the blood instead of going into the tissue where it's needed. Insulin resistance. Loss of beta cells that are trying so hard to make enough insulin that they basically burn out. Fasting glucose over 125 milligrams per deciliter. Normal is about 60 to 100. Hypoglycemia is below 60. Hyperglycemia is over 100. And if it's 125, in a couple of trials, then you have diabetes mellitus. The A1C glycosylated hemoglobin, this is too much blood sugar, affects hemoglobin inside the red blood cells and alters them in a way that is not, don't function as well and is damaging to them. The good thing about this A1C test is that it's a test over time. If your glycosylated hemoglobin is elevated, it means that you've had over a period of at least days, if not weeks, an elevated blood glucose. Whereas this could be an anomaly. Your blood glucose goes up and down all the time. You eat something and you get glucose, you produce insulin, it pushes it out. And so this is a snapshot of one moment in time where this is a little bit a longer period of time that you're analyzing. Should be less than 7% of your hemoglobin should be glycosylated. Problems with diabetes mellitus. Now, this is a huge problem in the U.S. nowadays, U.S. and other Western societies, because we eat too much. Everybody's getting heavier, and kids are getting type 2 diabetes now. And there are some populations that, especially in some Native American populations and others that have a very thrifty gene that allowed them to survive famine in times in the past. Now they retain fuels and store fuel so well that even normal amounts of food will make them fat. And there's a lot of diabetes. And this is like my age group and my kids' age group now. And so you guys as health professionals are going to be dealing with these populations. So a lot of things go wrong. For one thing, you have peripheral vascular disease. It damages the walls of blood vessels, and they won't carry blood properly, and you can't get enough blood into your feet and hands, and you have to get your feet cut off. It's a big deal. You get neuropathy, damage to the nerves, so that you can't feel your feet very well, and you get cuts, and they get infected, and you don't know it, and you can't get enough blood there for your immune system to counter it, and so you get big ulcers, and you have to have your feet cut off. It causes diabetes hyperglycemia, too much glucose in the blood. Diabetic ketoacidosis. Keto acids, if you can't get enough carbohydrate into your cells to keep you alive, and red blood cells and brain cells can only eat glucose, they can't eat fats and proteins, then your body takes fats and makes keto acids out of them. You can't convert fat into glucose, but you convert it into ketones, which are keto acids. They lose a hydrogen and become a ketone then. And ketoacidosis puts you in metabolic acidosis, which is also harmful. The ketones smell like acetone, so your breath smells like nail polish remover. Some people says it smells like bananas. Doesn't smell much like bananas to me, but I can kind of get it. You can have a hyperosmolar, I guess they're calling, hyperosmolar hyperglycemic non-ketotic syndrome. What does that mean? Well, it's not bad enough that you make ketones, but you pee so much that your blood gets too thick. Hyperosmolar means you have too much osmolarity in your blood. And it's not like you're retaining more solute, you're just peeing out all the water, and so your blood gets too thick. Can result in coma, diabetic coma. People wind up with, high blood sugar, which, causes all of this damage. Take insulin shot. If you don't have enough insulin, your blood sugar plummets, because maybe that's where the hypoglycemia on this particular slide came from, because if it drops down enough, you can go into a diabetic coma. People start feeling really bad, and they have to eat some little carbohydrate pills to raise their blood sugar back up. It's just really hard to maintain it at a decent level. People who are severely diabetic need to do blood tests pretty frequently to see if their blood sugar is going way up or way down. Dawn phenomenon. At night, you use a lot of insulin to put a lot of nutrients into the cells so you can build them back up from the day's efforts. You lift weights during the day, and then at night you have to rebuild those muscles bigger, hopefully. And so insulin is used a lot at night to help move nutrients into the muscles so that they can do their overnight recovery thing. And at dawn, you cut back on the insulin so that you can raise your blood glucose so you can get up and run around a little bit. And so you're likely to have a spike in blood glucose first thing in the morning if you are diabetic. And so it's called the dawn phenomenon. Here we have diabetic ketoacidosis. Changes in hormonal factors, or not enough insulin production, breakdown of fats to make ketones with, make these acids. Ketones start coming out in the urine and in your breath. The diabetic ketoacidosis, if it gets bad enough, acidosis, your pH has to stay pretty, 7.4. You even get to just beyond 7.35 and you're in acidosis. You get down much farther than that, and a lot of body functions start breaking down. Enzymatic reactions can't happen at those acidic levels. Kussmaul respirations, fast and slow breathing and stopping breathing and all that. Hyperosmolarity and your hyperosmolar hyperglycemic non-ketotic syndrome could be on that side of the ledger. One problem that happens is in the blood vessels of the eye. You get retinopathy, damage in the retina, and it can cause blindness. Severe uncontrolled diabetes can make people go blind. Coronary artery disease, damage to blood vessels, strokes, peripheral artery disease is a big deal. Infections that won't heal. Here we have some diabetic ulcers that simply won't heal. Can't get enough oxygen there. It's almost like compartment syndrome, where there's swelling, there's hardening of the tissues, there's compression on the blood vessels, there's damage to the blood vessels, not enough blood can get here to take the nutrients that are needed, and not enough oxygen can get there for the immune cells to use the oxidative burst to kill the infection. And you can't get the antibiotics in there very well either because you're not getting enough blood flow. Hyperbaric oxygenation helps out with this as well. Besides, debridement and antibiotics and, whatever, hyperbaric oxygen can deliver enough oxygen there in some cases to allow the immune system to do its work and allow the diabetic wound to heal. The adrenal cortex makes some stuff. It makes cortisol. That's its biggest player. It makes aldosterone, which is a big player too for water retention and sodium control in the kidneys. And it makes some androgens, testosterone, dihydrotestosterone. So those aren't only made in the gonads, but there's so little made in the adrenal cortex that we usually don't worry about it unless you have a growth or problem that makes too much of them. Adrenal cortex. Number one problem probably is an overproduction of cortisol. Cortisol is your stress hormone. It causes you to reutilize a lot of your nutrients. It will cause fats to be taken off of your limbs and mobilized for use in fighting whatever the stressor is. If you are lacking the stressor that needs it, those fats redeposit on the trunk and on the back of the neck. Very unfortunate. They don't go back where they came from. So Cushing's disease is where you make too much ACTH and it overstimulates your adrenal cortex. And the syndrome is if you have the same thing, but it doesn't necessarily come from this. Idiopathic, perhaps. So here we have the reduction of fat on the limbs. The redisposition, it's called the buffalo hump, on the back of the shoulders. On the trunk here, which deposited so fast that it caused some huge stretch marks on this guy. And it suppresses your immune system, because that's the other thing cortisol does. It prevents your immune system from going haywire and basically killing you. So under normal conditions, it's an immune suppressor. With too much of it, it suppresses it too much. You bruise easily, wounds won't heal. Hyperaldosteronism. Aldosterone acts in the kidneys to cause you to retain sodium and thus retain water. Well, that seems like ADH. Not exactly, because ADH changes cause you to retain or pee out pure water. So it concentrates or dilutes your blood because you have the same amount of solute, but now more or less water. Aldosterone causes you to retain sodium, and then the water follows by osmosis. So you get both solute and water. So you change blood volume, but you don't change the osmolarity. So you have two different systems for maintaining blood volume. One also controls how thick the blood is. So aldosterone, because it causes you to retain sodium and thus water, too much, you have to retain too much sodium, you retain too much water, your blood pressure goes way up. Okay? Hyperaldosteronism, the main thing is hypertension. Hypoaldosterone, which proves that aldosterone does other things besides retaining water, First of all, it's called Addison disease. This is something that President John F. Kennedy had, Addison disease. And it causes you to retain too little water and too little sodium. So you could have hypotension. Maybe your ADH could be accelerated and make up for it. But it also causes some other changes that cause a change of pigmentation. The palms of your hands, the stripes here get really dark. Dark pigmentation of the fingertips, under the nails, and of the gums. Often, cortisol levels go with it because these both come from the adrenal cortex. So it's not uncommon to have have Cushing's and hyperaldosteronism and have low levels of both too, or at the same time. Could be because of hypopituitarism. You might not make enough ACTH, adrenal cortex stimulating, adrenal corticotropin hormone, and therefore you're not stimulating the adrenal cortex enough to begin with. If you have an overgrowth of the adrenal cortex that causes you to increase your production of those androgens and estrogens and gonadotropins, basically, or not gonadotropins, but the androgens and estrogens that would normally come from the gonads, then you can have the same situation you would have if you overstimulated or understimulated the gonads. Normally, your testosterone, dihydrotestosterone, and what little bit of estrogens are produced in that adrenal cortex are not enough to make a big difference. You know, the negative feedback, if you make a little bit too much, you negatively feed back, and your gonads cut down on the amount of production, and they are way more powerful, so there's not a problem. But if there's a real problem with the adrenal cortex, and you make way too many of them, then you have virilization, overproduction. In a female, if you made a lot of extra androgens, you could have a hirsutism and grow a beard. Feminization, if there's make too many estrogens. Virilization, if it's a male. You know, this is a young kid who has had an oversecretion of testosterone, and it's caused a huge amount of muscle production and hair production at a very early age. Doesn't say how old he is. Young boy. And if you remember, the adrenal medulla is where you make adrenaline. That's where the term adrenaline comes from, is the adrenal gland. The adrenergic receptors, they are turned on by adrenal hormones. But they're the adrenal medulla. It makes epinephrine and norepinephrine and releases them as hormones through the bloodstream, both of which are sympathetic receptor stimulators. And so it would give you a shot of adrenaline, or like your sympathetic nervous system was overstimulated, fight or flight type stuff. So, you know, here we have an overgrown tumors of the actual chromaffin cells that are making the epinephrine and norepinephrine. They secrete those catecholamines, epinephrine and norepinephrine. It can be every once in a while, or it can be all the time. And it's sympathetic stimulation. High heart rate, sweating, can't go to sleep, breathing fast, dilated pupils, all the stuff that goes along with fight or flight. The endocrine system.